first of all, I need to say we're supposed to go into session at 1, so please keep your testimony. We want everybody to speak, but please keep your testimony succinct and to the point and try not to repeat. So to start with Senate Bill 158, can I see hands on who's here to testify in favor? Okay, and against? Okay, and then Senate Bill 230, in favor and against? Okay, all right. Senator Henderson, whenever you're ready, we will begin the hearing on Senate Bill 158.
Thank you, Madam Chairman. State Senator Mike Henderson from the 3rd Senatorial District for the record, presenting Senate Bill 158 today, non-opioid pain management. Senate Bill 158 is designed to address the rising concerns surrounding opioid misuse and abuse by focusing on providing alternatives to opioid prescriptions for individuals at an elevated risk. And I'll say that again. This is dealing with people who have an elevated risk of taking opioids. The bill introduces the concept of an elevated risk of opioid misuse, which includes a history of substance use disorders, an advanced health care directive that limits opioid use, increased risk of opioid overdose or dependency based on the patient's age or medical condition, and contradictions for opioid use due to other prescribed medications. The legislation prohibits health benefit plans from denying coverage for non-opioid pain treatments if prescribed by a licensed health care professional to patients at elevated risk for opioid misuse. By reducing reliance on opioids, this legislation is a proactive step up in the fight against the opioid epidemic. And I want to give a few statistics to tell you why I think this is really important. First, I've had this happen to somebody in my community. I won't go into details, but we had a young man that I knew personally, injury in sports, got on opioids, and catastrophic ending in the end at a very, very young age. Some of the statistics, in 2023 in Missouri, there were 1,456 opioid-related overdose deaths. I'm not laying that at anybody's footstep, nobody, but it's a fact. This accounts for 77.1% of all drug overdose fatalities. Some of them were probably legal, some of them were probably obtained illegally, of course. On average, last year as a country, we lost more than 220 Americans every day to an opioid-related drug overdose. In Missouri, there were 47 opioid prescriptions per 100 people. And I'll say that one more time. There were 47 opioid prescriptions for every 100 people. 90% of all surgical patients in the U.S. are prescribed opioids. And again, what I'm trying to do with this bill is say they have to at least look if you have these risks, high risks, at other avenues for management of pain. And with that, I'll take any questions.
I don't have any questions, so I'll ask for the first witness in favor of Senate Bill 158. Just a reminder to please fill out a witness form and leave it on the desk.
Madam Chair, David Winton here on behalf of National Association of Social Workers, the REACH Foundation, and Gateway Foundation. I want to go on record in support of Senate Bill 158 and thank the sponsor and you for having us come forward. The sponsor did a great job of explaining the bill. I'd like to just add a couple of very small details to that. The first is there is no what the bill essentially says is the insurer can't substitute an opioid in the place of a non-addictive pain treatment. The insurer, the PBM, still has the ability to do prior authorization. They have the ability to do step therapy. And so in many cases, we would expect if somebody was assigned a medication that was different than an opioid for pain relief, they would essentially be told, hey, you've got to try high-dose ibuprofen or naproxen or something like that for 24 hours to see if that would relieve your pain. So we're trying, I don't think anybody's trying to take away the ability of insurers to regulate the plans, but really appreciate this issue and the societal costs associated. All of those organizations that I represent are folks that deal directly with individuals that have substance use disorders, and many are with opioid addictions. So I'll close there and be happy to answer any questions.
Questions for this witness and for the senators that came in. We are on Senate Bill 158. Any questions for the witness? Seeing none, thank you for your testimony. Next up in favor.
Madam Chair, members of the committee, Alex Seaton representing Prevent Ed this afternoon. Appreciate you taking time. Senator Henderson and David did a great job explaining the bill. Prevent Ed is an organization that is dedicated to substance abuse, misuse, so we appreciate him bringing it forward. I will stop there in essence of time, but happy to take any questions.
Questions for this witness on Senate Bill 158? Seeing none, thank you for your testimony. We're going to pause real quick and take roll since we have a quorum here, I believe. Barb, please call the roll.
Senators Crawford.
Here.
Gregory. Here. Brown. Here. Huff. McCreary. Here. Mosley. Trent.
We do have a quorum. Next up, in favor of Senate Bill 158. Seeing, nope.
Chair, members of the committee, Henry Telemock with the Missouri Pharmacy Association, as well as the Assisted Recovery Centers, to go on record as in support. I think the previous witnesses said it best. We just want to make sure that patients have an alternative to the medications that they need.
Thank you for your testimony. Any questions for this witness? And we're on Senate Bill 158. Seeing none, thank you for your testimony. Next up, in favor of Senate Bill 158.
Madam Chair, members of the committee, Sarah Schlemeyer here on behalf of the American College of Obstetricians and Gynecologists. We also want to express our support for the bill. Obviously, whenever a woman is pregnant, she has very strict medication regimens that she can be on, and so ensuring that the doctors are leading that prescription is very important to us. So,
questions for this witness? Seeing none, thank you for your testimony. Next up, in favor.
I was going to say good morning, but I think it's afternoon. Good afternoon, members of the committee, Madam Chairwoman. My name is Arnie C. Acedinov, State Public Advocate. I'm fully in support of SB158. This is common sense legislation, it's good public policy, and it's saving lives. It gives an alternative and options to individuals who are hooked on opioids. It gets individuals away from that bad element. It cuts down on crime, saves us correction costs, and saves us other residual costs and unfortunate consequences. It gives some Missourians a second chance that they truly need to have health care, and it cuts down on health care cost in the long run. There should be no opposition from the medical field or the insurance companies. If they do, in my opinion, it's self-serving. This bill clearly saves Missourians' lives. I'm in full favor of this bill, and I appreciate having the opportunity of testifying in favor of SB 158.
Questions for this witness? Seeing none, thanks for your testimony. Next up, in favor of Senate Bill 158. Seeing none, anyone here testify in opposition to Senate Bill 158?
Good afternoon. Good afternoon, Senator. My name is Hampton Williams. I'm with the Missouri Insurance Coalition to testify in opposition to the bill. First off, we appreciate Senator Henderson highlighting this issue. We are unaware of any circumstance where any insurance provider is forcing addicts to take opioids. So with respect to the problem that's attempted to be addressed, we do not believe that there is a requirement or mandate that healthcare professionals are in fact forcing opioids on addicts, or that certainly insurers are requiring them to prescribe it. This type of bill is, while it's the first time in front of this legislature, states around the nation have addressed this concept of non-opioid treatments. The difference between those other states and what's being presented here is that those states proposed non-pharmacological treatments. This legislation expressly provides that the only opioid, the non-opioid treatment would be a pharmacological treatment. And in fact, 2 weeks ago, the FDA approved a, quote, novel non-opioid treatment for moderate to severe acute pain. This market is not developed. And so to the extent that the focus of this bill or an unintended consequence of this bill would be to require that insurers either provide prescriptions for one provider or one manufacturer in this nation, that would have a substantial increase to the costs associated with care. It's estimated that this new prescription drug, non-opioid painkiller, would have an expense of approximately $420 a week, which would be about $22,000 a year. Now, the effect of this bill would not only require insurance providers to cover that, and if you look at page 2, lines 25 and 24 and 25, it states that the healthcare professional, quote, prescribes a non-opioid medication treatment, and then it states that it's unlawful for an insurer to deny coverage for that non-opioid prescription. And so we do believe that this does impose a mandate for us to provide coverage for the prescribed non-opioid medication. The other issue that this raises is that it prohibits co-pays from being imposed for name brand medications. If you look at your traditional insurance policy, right now you will have a different co-pay amount for either generic medications or brand name. This would mandate that we would have to provide that brand name copay, the same thing as generic. And so the other final issue I'll raise is that a documentation requirement on page 2, lines 36 through 40, it identifies that the health benefit plan can only receive clinical notes on the determination of whether or not there's an individual who is eligible for an opioid addiction. We think that the normal documentation that's provided with the treatment should be appropriate, that section should not be provided. And I'll give you an example. One of the criteria identified in the statute to qualify is the execution of advanced health directive. And this statute would not require that advanced health directive to be provided to the insurer. I don't know why the existence of that document would not be provided, and I don't think that it's certainly the intent of any drafter or sponsor to not provide information to the insurer, but we would think that it would be appropriate, just as any other course of treatment, that if there's a determination made by a physician or a healthcare provider that someone's qualified for this, that they provide the standard documentation.
Thank you for your testimony. Questions for this witness? Senator McCreary.
I just wanted to get clarification on where you were getting the cost per day. My understanding is the cost per day is half of what you said, so.
Yeah, so there are estimates on the dosage, and the question is whether or not the dosage amounts are someone having to take a pill twice a day or 4 times a day. Now, I believe it's $15.50 per pill, and so that's that estimate question.
And then to give a cost, to share with the committee the cost, the annual cost, isn't this a product intended for short-term use? Versus you said an annual cost. That's not the way the product is indicated per prescribing information.
Well, and to the extent that there's not, again, the concern that our members have is that this bill would not allow 4-step therapy or those other mechanisms that insurers use to identify if the course of prescriptions are being followed. And so that's the general concern.
Thank you.
Further questions for the witness? Senator Brown.
So what's the cost annually or per day for an opiate then?
I don't have that figure immediately available to me. What I do understand is it's approximately $2.
Okay, so it's significantly cheaper than what we're talking about here then.
It is.
So that's what you're worried about, is the cost, not the treatment.
There is certainly a cost element of it.
So, yeah. So it's basically $33 a day less to get somebody hooked on Oxycontin than it is to use a non-habit forming drug. So that's what you're concerned about, but is the money.
We are concerned about the viability of our business, correct?
Thank you, Madam Chair.
Further questions for the witness? Seeing none, thank you for your testimony. Next up in opposition to Senate Bill 158.
Madam Chair, Shannon Cooper today representing America's Health Insurance Plans and Blue Cross and Blue Shield of Kansas City. I'll be brief but follow up on the Hamptons. As health plans, we have no issue whatsoever if you want to put something in state statute that says an individual who chooses not to have an opioid cannot be forced onto one. We're happy to do that. I've never seen any evidence of any health plans out there that have done that. But if you're comfortable and want that in state statute, we don't have a problem with that whatsoever. I think we all realize what happened with the opioid addictions, and we don't want to be a part of that. The flip side is, and I probably to save time since we've got so many people here who want to testify on the other bills, is to bring you some stories about what's taken place in the last month regarding a certain non-opioid painkiller out there that has just entered the market, and our belief that the effectiveness of it is no greater than any other non-opioid pain reliever that is out there today. We don't want to lose our ability to make sure that we are using the right product for our members. And with that, Madam Chair, I'll bring your stellar staff that story, and you all can share that with the committee members, and maybe that'll make this process go a little faster.
Questions for this witness? Seeing none, thank you for your testimony.
Thank you. Madam Chair, would you like that emailed or hard copy?
Either way would be fine, and we'll disperse it to the committee.
Okay, thank you.
Next up, in opposition to Senate Bill 158. Seeing none, Senator, any final anyone want to testify for informational purposes only for Senate Bill 158? Seeing none, Senator, any final comments?
Just real quick, thank you for hearing the bill, first of all. Second of all, think of the cost to the future, too, because when these people get hooked on those opioids, we know where it goes from there. It goes from prison to family problems to health issues, and a lot of times the state has that burden. So it's not just on the families, which it is on them, and on the individuals, but it's also with the state. Thank you.
Thank you, Senator. This will conclude the hearing on Senate Bill 158. Next up, we will have the hearing on Senate Bill 230. Senator Brown. Senator, you can feel free to start whenever you're ready.
For the record, my name is Senator Ben Brown from the 26th District, and I appreciate the opportunity to present Senate Bill 230, legislation designed to reform the burdensome and often inefficient prior authorization process within our healthcare system. We all recognize that prior authorization was initially intended as a cost control measure, a way to prevent unnecessary procedures and reduce waste. However, over time, it has morphed into a significant administrative obstacle, delaying critical medical treatment, overburdening physicians, harming patient outcomes, and driving up the cost of health care. In fact, during the interim, Chair Crawford held a special committee meeting with the purpose of investigating the causes contributing to the rising price of health care. A variety of experts in the field came to testify, and the one common refrain that we heard was the impact that the burdensome prior authorization process had in regards to driving up prices. According to a survey by the American Medical Association, 35% of physicians have to hire staff just to work exclusively on prior authorizations. MU Healthcare staffs approximately 50 people just for this purpose. Another implication of the current system is that a hospital will begin prepping for a procedure only for a prior authorization to be denied. Despite not being able to proceed, the costs of that prep are still incurred, resulting in further increases to healthcare costs. Senate Bill 230 introduces a balanced, common-sense approach by implementing a gold carding program that rewards high-performing healthcare providers with fewer administrative hurdles. Under this bill, any provider who has had at least 90% of their prior authorization request approved within a 6-month evaluation period will be exempt from prior authorization requirements for those services moving forward. Physicians and healthcare professionals should be spending their time where they are needed most, with their patients. Yet today, they are forced to dedicate countless hours each week to submitting prior authorization requests, navigating appeals, and dealing with insurance denials. According to the AMA, 9 out of 10 physicians reported that prior authorization had a negative impact on patient clinical outcomes. Also, 94% reported that prior authorization delayed access to necessary care. SB 230 cuts through that red tape. By establishing a gold carding system, this bill ensures that providers with a proven track record of medical necessity no longer have to go through a repetitive, burdensome approval process. I understand that some may have concerns that reducing prior authorization requirements could lead to overuse of medical services. However, this bill includes several critical safeguards to prevent this. The 90% approval rate threshold ensures that only providers who consistently demonstrate sound medical judgment receive a gold card status, and includes a 6-month look-back provision so that insurance companies can ensure continual compliance. Insurers will still have oversight and can revoke gold card status if a provider no longer meets the required standard. What this legislation does not do is allow providers to bill for services outside their scope of their license or misrepresent claims, maintaining integrity and accountability in the system. SB 230 does not eliminate necessary oversight, it refines it, ensuring that prior authorization is applied only where it is truly needed rather than creating unnecessary barriers to patient care. At its core, SB 230 is about striking the right balance between necessary oversight and unnecessary bureaucracy. It ensures medical professionals who have already demonstrated responsible decision-making are not forced to jump through hoops that serve no real purpose. It empowers providers, improves patient outcomes, and ensures that administrative processes support rather than hinder quality health care. By passing this legislation, we take a significant step towards a more efficient, patient-focused healthcare system in Missouri. I urge this committee to advance Senate Bill 230 and bring much-needed relief to our healthcare providers and the patients who depend on them. Thank you, and I'd be happy to answer any questions.
Questions for the bill sponsor? Seeing none. First up in favor of Senate Bill 230, please come forward.
Good afternoon, Chairwoman Crawford and members of the Insurance and Banking Committee. My name is Andrew Wheeler with the Missouri Hospital Association, and I'm here to provide testimony in support of SB 230. Senator Brown did a really good job of setting this up, and I can't really say anything more as to regard of why this process was set up. He covered that very well. I would like to add a couple things, though. The sheer volume and complexity of the prior authorization process that exists today that insurers have added within the last 10 years, it's causing the insurance companies to act as the healthcare decision makers and not the doctors who are treating the patients. Because of the volume and complexity of current prior authorization systems, it's causing providers to shift away from caring for people to jump through hoops and a never-ending cycle of prior authorization requests. I left some material with the cover sheet today, and I'd be happy to send that to any one of you in this group electronically if you'd like to see that. It lays out more of the information that supports what I just said. Medicare Advantage is 10% of our population throughout the country. Just for 10% of our population, the Kaiser Family Foundation released a report that said that 49.8 million prior authorization requests were requested in 2023. Again, that's only for 10% of the population. Whenever you think about that, that's 95 requests per minute of every day of the year. If it takes 15 minutes to make these requests, again, on 10% of the population, that's 6,000 full-time equivalent positions just to handle one plan type. That's a tremendous workload that is burdening the healthcare system today. So, the question comes up, is that the best use of doctors' time? Asking them to try to obtain approval to provide the care they know those patients need. Senator Brown's proposal today, as he said, would help reduce those administrative costs. It's a good start. And it would also align incentives, because those who are doing really well right now would get an exemption. They'd get administrative relief. They want to keep that. That gives them incentive to continue doing well. Those who are not at the 90% rate, it gives them an incentive to do better. And if insurance companies think there are too many hospitals and physicians that are getting the gold card, then they need to take a look at the utilization management policies and get rid of the wasteful prior authorization policies that exist today with really high approval rates, because there are many. We think the proposal is a step in the right direction, and it would certainly help within the Medicaid managed care space as well as the fully insured space, those areas that is in the jurisdiction of the state of Missouri. So MHA urges this committee to advance the bill and for the General Assembly to enact SB230. So at this time, be happy to answer any questions.
Questions for the witness, Senator Brown.
Yeah, real quick, what's the process to obtain a prior authorization? What's the turnaround time on that? Once a provider tries to get a prior authorization?
Yeah, it's a really good question. I left some materials in there that helps lay that out. A couple of them are from the Department of Commerce and Insurance that's within there. I can send that to you. But there's also some information that is put together just for the fully insured market, which has its own process, as well as the Medicaid managed care that has a different process. It consists of multiple layers. First, you try to get the authorization. Then the insurance company lets you know if that's approved or not. If it's denied, you ask for a reconsideration. If a reconsideration process is approved, patient's scheduled. If it's denied, you go on through a grievance process, first level of appeal. If that's denied, you go to a second level appeal. So to answer how quick it takes to do this, it can be as little as 2.5, 3 days if it's approved on the first request. But if you have to go through reconsideration and the first 2 levels of appeal, that can take up to 101 days, and that's according to Missouri statute. 101 days is a long time for a patient that needs treatment to wait to receive that care.
Long time when you're dying, isn't it?
Long time if you're dying. Long time. Now, what's even more interesting, the Medicaid managed care space, it can be up to 247 days because it works through a different process. So again, to answer your question, it depends on the plan type, and it depends on how quickly you get that approval and how far the providers are willing to fight for that prior authorization. So much so, and there's so much volume that many give up. And that's why we think this would really help with the system that exists today.
Further questions for the witness? Seeing none, thank you for your testimony. Next up in favor of Senate Bill 230.
Good afternoon. Chairwoman Wheeler and committee, thank you for allowing me to speak today in support of Senate Bill 230. My name is Michael Rothermick, and I'm a physician. I've been the chief of staff at a small critical access hospital in Herman, Missouri since completing my service in the Navy in 2006. At Herman Hospital, I've worked in the ER as a hospitalist and a clinic provider in all of our rural health clinics in both Gasconade and Montgomery counties. In addition, I'm in collaborative practice with several of our PAs and nurse practitioners. Our hospital straddles Gasconade and Montgomery counties and is the only hospital in either county where we also have no urgent care facilities. Like most critical access hospitals and rural health clinics, our organization has struggled financially. And for the last 10 consecutive years, we were rated as having an ongoing financial concern by our independent auditors. In my nearly 20 years with our organization, I've seen significant changes in healthcare with some amazing life-saving advances, the change to electronic health records, and unfortunately the rise in the number of things requiring prior authorization, as well as the complexity of meeting those requirements. Far too frequently, coverage is initially denied and often only begrudgingly approved after multiple appeals. When I started working at Herman Hospital, the relatively rare prior authorizations were a minor annoyance that were dealt with mostly by the nurse I was working with in the clinic that day. but prior authorizations now require a separate department in our organization with well over an FTE, and despite this, clinic providers and nurses devote more time than ever to trying to navigate the prior authorization process, taking time away from patient care. All of this drives up the cost of healthcare for everyone, but perhaps just as importantly, it's a major source of job dissatisfaction for both providers and nurses. While passage of this law will not erase our financial struggles, I believe it will have a tangible benefit on our bottom line and decrease the chance that we ever have to shutter our doors. In addition, all of the providers and nurses that I work with are excited about the possibility of decreasing their administrative burden. Few people succeed in getting into or completing medical school, PA school, or nurse practitioner school without being a competitive person themselves. I can't help but feel that achieving and maintaining gold card status as a provider may well result in providers better learning the insurance guidelines so that upon further review, fewer of their referrals, treatments, tests, or procedures might ultimately be denied. And it will motivate us to fight harder for the ones that we know our patients truly need. I got into medicine to take care of patients, not spend my days fighting to get patients the care they need. Thank you.
Questions for the witness? Seeing none, thank you for your testimony. Next up in favor of Senate Bill 230, I would just remind you it is 10 till 1, and so we need to move along fairly quickly. We want to hear from everybody, but we need to be succinct. Thank you.
Thank you, Madam Chair. I'm Dr. David Barb, a family physician from Mountain Grove, Wright County. I've been in practice there for 41 years. I won't speak to some of the technical things I've mentioned. I fully agree, and I thank Senator Brown for bringing this forward. This has been terrible disruption for patients, a tremendous burden on physicians for way too long. This has been 20-plus years since this problem has grown. This country doc from Southern Missouri was president of the American Medical Association in 2017, 2018, when this was recognized to be such a problem that the AMA convened the relevant national stakeholders, including America's Health Insurance Plans and the Blues and the American Pharmaceutical Association, and came up with a consensus statement, 4 items. First one, Senator Brown's bill, basically. We need a structured gold card type program. Simple, elegant, doesn't muddy the water. We're long overdue. That was almost 8 years ago now, and there's been very little progress. So appreciate this moving forward.
Thank you. Questions for the witness? Seeing none, appreciate you being here today. Next up in favor of Senate Bill 230.
Thank you to the committee. My name is Deepa Mokshigundam. I'm here on behalf of the Missouri chapter of the American Academy of Pediatrics. I am a pediatric cardiologist with a special focus in pediatric heart transplant and heart failure, and I'm on faculty at WashU, although I'm not representing WashU in any official capacity today. And I applaud Senator Brown's introduction of this bill to help ease this unnecessary burden. As a pediatric heart failure and transplant specialist, I care for some of the sickest children in our state, both with heart failure and who have undergone transplantation, who rely on things like life-sustaining medications and visits with their cardiologists to ensure that they can live a happy, healthy, and long life. But the burden of prior authorization for things like immunosuppressive medications or heart failure medications is a real danger to the health of these children. And the burden of this is felt by pediatric providers across all subspecialties and includes things like asthma controller medications for children with asthma, anti-epileptic medications for children with seizure disorders, and interruptions in these medications can lead to hospitalization because of things like breakthrough seizures, asthma attacks, and for my patients, things like transplant rejection. In addition to that, as a subspecialist in pediatric cardiology, I often see patients that drive 3 and 4 hours across the state to see me for consultation for a heart problem that they might have. In cardiology, we use a diagnostic study called an echocardiogram to help in some diagnosis, and because of the specialization in doing a pediatric echo, we offer that in our clinics. It's not something that most children in our state can just drive down the street and get done by an expert in performing this type of test. When kids come to see me, they have to miss an entire day of school. Often, their parents have to miss an entire day of work. And sometimes waiting and this sort of test getting caught up in prior authorization not only makes me worried that I will have to bring them back on another day and again miss another day of school, another day of work, have to drive 3 hours back and forth to St. Louis to get it done. or I'm risking my patient getting a huge bill in the mail for this test. So I've had patients also who have had new prior authorization requirements for medications that they've been on, including things like transplant immunosuppression. And to fill that gap, the patient's doing everything that they need to be doing correctly. They notice they're running out of meds, apply for a new prescription, suddenly a new prior auth comes up. And there might be a gap of a week, 2 weeks in this life-sustaining medication, and we do our best to help those patients cover that cost with donation funds and things like that, but the system just shouldn't be this way. I've had patients with heart transplants or needing heart transplant evaluation also have delays on getting routine heart transplant testing and getting delayed and even being evaluated for a heart transplant because of authorization delays. Lastly, we've also had to delay discharge from the hospital for patients because an essential medication requires prior authorization. And I don't know that there are many medications for which an extra day in the hospital is any less expensive than just getting the medication to them. In the last few years, I've noticed that the frequency of needing prior authorization
And if you
has
could
been-
please wrap it up, because we're
Oh, yeah.
running out of time.
Yep. The burden has also been increasing. And last thing I'll say is I am early in my career as a pediatrician, as a pediatric subspecialist. I will say that the increasing amount of administrative burden does lead to a lot of burnout. And I've had colleagues that, early in their careers even consider leaving clinical practice because they're not spending their time caring for patients. Thank you.
Thank you for your testimony. Questions for the witness? Senator Gregory.
Thank you. Ma'am, doctor, if you
Ma'am.
don't mind. Oh, sorry. That's okay. I got a real quick question. So as a provider, I hear what you're saying, and it's unfortunate to hear those examples, right? And I also think prior authorization can almost be used as a weapon to abuse certain situations. My fear, of course, is without some sort of prior authorization, there can be abuse the other way. That's probably why we have that. Can you talk to me as a provider, a direct provider, what kinds of protections you think are in here that will stop providers from abusing their recommendations and prescriptions?
I might ask for clarification about what you mean. I would say that the prior authorizations that I typically have to do, again, as many of my colleagues have explained, I'm lucky that I work for a large academic center that employs, again, people whose sole job is to deal with prior authorization. The prior authorizations that I often have to do with these types of routine testing, a heart ultrasound, medications for transplant, medications for heart failure, and then larger, more complicated things in terms of complex medication for treating heart transplant and rejection and things like that. I will speak personally, I don't directly benefit per se in what I am, ordering and, recommending to my patients. That's all evidence-based medication. So I guess I would ask clarification on sort of.
Well,
what
just
you said that.
like you're saying, look, if it's truly a routine, I think, and they're being denied, that prior authorization system is abusing its power, if you will. But on the same token, you're not hurt by ordering a whole battery of tests. Why not order 500 tests? Who cares? Doesn't cost you, barely cost the patient, right? I think it can get abused, is my fear. I think it can be abused either way. What types of protections are in place? Maybe it's a better question for the bill sponsor, but what kind of protections are in place to make sure that providers aren't abusing it? They're not just prescribing whatever they feel like prescribing at any time because, oh, well, it doesn't cost us anything.
Yeah, I'll let the senator speak, but from my perspective as a pediatric provider, my patients are children, and so my job is to limit their exposure to medications to just what they need, limit their testing to really only what is necessary, because they're children and we only want to do what we need to do.
Okay, thanks.
Yeah, if I could just give a quick response. So this bill contains a 6-month look-back provision. So every 6 months, the insurance company can go in and analyze everything that would have normally gone through the usual prior authorization process, and they can really set the criteria to an extent by how they rate that. So they have to maintain that 90% or more of everything that would have had to go through the prior authorization process would have been approved. So if they just put out a whole bunch of unnecessary tests that would have normally not been approved or would not have been approved with the prior authorization, then they will lose that gold status and they will no longer have this, and they will have to go through the normal process.
And then how long before it could be reinstated? Is it another 6 months? So it's like, hey, abuse it for 6 months, let off the gas for 6 months. Abuse it for 6 months, let off the gas for 6 months. Is that how this works?
Well,
If you want to abuse it.
I don't know that I see a scenario where someone's going to abuse it for 6 months and then take 6 months off abusing it. So I think that generally this would be something that would be more of a habitual thing.
Mm-hmm.
And so if somebody was, say, even if they only had more than 10% of their claims that wouldn't have been approved in a prior authorization, every few months still, with every 6 month look back, they're not going to qualify.
Yeah, so Senator, I just want to be clear. I'm with you. I think there's a lot of abuse in prior authorizations. I just want to make sure that we don't swing the pendulum all the way back and it starts being abusive the other way. So thank you.
Further questions for the witness? Seeing none, thank you for your testimony. Next up in favor, and I'm going to start limiting you to like 1 minute because I want to get the other side in too, so keep it to 1 minute or less.
Madam Chair, members of the committee, Jacob Scott, registered lobbyist for the Missouri State Medical Association and the Missouri Association of Osteopathic Physicians and Surgeons. Very thankful to the sponsor for bringing the bill forward, and we're just here in support because we believe that this restores balance to a system that just simply needs some work to protect patients. So thank you for your time and happy to answer any questions.
Questions for the witness? Seeing none, thank you for your testimony. Next up in favor.
I'll be faster than Jacob. This is Rachel Bauer here in favor of Senate Bill 230 on behalf of the Missouri Gastroenterology Society and the Missouri Osteopathic Association. Any questions?
Questions for the witness? Seeing none, thank you for your testimony. Next up in favor.
Thank you, Madam Chair. Shannon Hawk here today on behalf of the Missouri Society of Eye Physicians and Surgeons, going on record in favor.
Thank you. Thank you. Questions for the witness? Seeing none. Next up in favor.
Madam Chairwoman and member of the committee, I'm Kathy Harness here today on behalf of St. Luke's Health System in Kansas City, and we want to go on record in support of Senate Bill 230.
Thank you for your testimony. Any questions? Seeing none. Next up in favor.
Thank you, Madam Chair. Kara Hoover on behalf of SSM Health, here on record in support of the bill.
Thank you. Questions for the witness? Seeing none. Next up in favor.
Madam Chair, David Wynn here on behalf of BJC Healthcare, Cox Health, National Association of Social Workers of Rankin Jordan, Bridge Hospital, as well as Missouri Association of Rural Health Clinics. Want to go on record in support of the bill and thank the sponsor and the committee.
Thank you for your testimony. Any questions? Seeing none. Next up in favor.
Garrett Webb, registered lobbyist for the Missouri Psychological Association. We want to reduce barriers to access to mental health care in the state, so in support.
Thank you. Questions for the witness? Seeing none. Next up in favor.
Madam Chair, members of the committee, Sarah Schlemer here on behalf of Quest Diagnostics, the American College of OBGYNs, Jeff City Medical Group, Signature Medical Group, and the Missouri Ambulatory Surgery Center Association. Real quick, I want to make one point. We've heard a lot of great testimony today about providers who are directly in contact with their patients, but we have the labs. So the way it works with labs for prior auth, so our Quest Diagnostics labs, they get the sample. The sample doesn't have a long shelf life, so they run the sample, and then they have to submit for reimbursement. So whenever they submit for reimbursement, that's when they figure out if there's a prior auth on the test. So at that point, then the our Quest people have to go back to the provider and ask for a lot of patient data that they don't want to have, and nor do they have on record. So they have to work through this really long administrative process to get a prior auth for a test that there's not a lot of consistency on if the test has a prior authorization or not. And about 90% of healthcare decisions are based on our lab tests, and so that's a pretty big administrative burden. So,
thank you for your testimony. Questions? Seeing none. Next up in favor.
Could you send me some background on that?
Madam Chair, members of the committee, Will Mars on behalf of Mercy Health Systems, just want to go on record in support and thank the sponsor for bringing it forward.
Questions for the witness? Seeing none. Thank you for your testimony. Next up in favor.
Madam Chair, members of the committee, my name is Alex Tuttle on behalf of University Health out of Kansas City, Golden Valley Memorial Hospital out of Clinton, and Hannibal Regional Hospital. We would like to first thank the sponsor for bringing this bill forward and go on record of support of Senate Bill 230.
Thank you. Questions for the witness? Seeing none. Next up in favor.
Madam Chairwoman, members of the committee, Olivia Wilson here on behalf of University of Missouri Healthcare. The sponsor said it well. We employ a department of over 50 people just to deal with prior authorizations and insurance denial appeals. I'm happy to take any questions, but that's all. Thank you.
Questions for the witness? Seeing none, next up in favor.
Chair, member of the committee, Henry Telemack with the Missouri Pharmacy Association. I'll just say ditto. In support.
Questions for the witness? Seeing none, next up in favor.
Madam Chair, member of the committee, Brian Bernskater here on behalf of the Missouri Academy of Family Physicians. Just want to go on record in support. You all have heard a lot of great testimony.
Questions for the witness? Seeing none, next up in favor.
Thank you, Madam Chairwoman, members of the committee. Hopefully I'll make it under a minute and 10 seconds here. Arnie C., A.C. Dinoff, State Public Advocate. This is common sense legislation. This is finally putting Missourians first. We don't want to turn into the United States Veterans Administration and their procedures, which puts people's lives in jeopardy, in my opinion. We need to get rid of the 100-day process and the 274-day process. Let's not have Missouri healthcare turn into like the federal government does with certain healthcare for United States citizens. This is on the side of the patient and puts Missourians' health first. Prior authorization puts red tape of the procedures, tests, or other necessary medical treatments. This bill cuts the red tape, gets patients faster access in critical healthcare situations. This is smart healthcare that makes better health and saves lives. There needs to be a firm focus, and it must be for Missourians' health. That must be the number one priority. In my opinion, this will save providers hundreds of millions of dollars. If you take 6,000 people, it was brought up, times a $42,000 salary with benefits and pension, that's over $300 million. For those reasons, I highly support SB 230. Thank you, Madam Chairwoman.
Thank you for your testimony. Questions for the witness? Seeing none. Next up in favor.
Thank you, Madam Chair, member of the committee. My name is Megan Howerton here on behalf of Mosaic Life Care and the Missouri Ambulance Association here in support of the bill.
Thank you. Questions for the witness? Seeing none. Anyone else in favor? Seeing none. How many to testify against? Raise your hands. Okay, I'm going to allow more than a minute because I want to be fair on both sides. And is there anyone for informational purposes only? Okay, so if you can keep it succinct, but I will allow more than a minute because I don't want to favor one side over the other.
Good afternoon again. Again, Hampton Williams for the Missouri Insurance Coalition. With respect to the prior authorization issue, again, the efficacy of prior authorization isn't in dispute in this bill. All this bill would do is create a threshold to exempt certain, I guess, high-performing entities from this prior authorization process. So the bill concedes the efficacy of prior authorization. I think there's three areas of dispute with respect to the bill itself. One is how do we identify who qualifies as a high-performing provider. This bill provides two tracks. One is to identify either specific physicians as eligible or larger systems. Our members really have issues with larger systems. And the reason is that if you are taking the aggregate amount of that 90% threshold through the larger systems, that would allow specific physicians who would not be otherwise qualified to meet that standard, and it'll kind of allow them to hide in a larger pool. The second issue is how do we quantify what high performing is? Currently, the way the legislation is drafted, it identifies a 90% threshold with respect to denials of prior authorization. There's not a consideration of how many prior authorizations are filed for a specific type of care. And one of the concerns that we do have is, as written, the bill would not consider prior authorizations that are on appeal. And so there is a way for providers to game the denominator, to reduce the amount of numbers by appealing all prior authorization denials to the hilt. And so that would be a concern. I think that there's ways to adopt different standards which could still address the same concern. And the final issue is the breadth and treatments that are eligible for the program. There's a second portion which is in section 376-2106. That section does not particularly apply to gold carding itself. Rather, it imposes what would be a criminal liability standard on a contractual relationship. It would prevent the ability for insurers to either claw back or take back prior authorizations unless there is knowing misrepresentation. It would allow and require insurers to make full payment on a health provider's negligent misrepresentation, which I don't think is an intended consequence. Also, there's not a definition for what the term substantially performs under that section. It's not defined, and obviously to the extent that an insurer is being paid for 100% of a service, we should expect that service to be rendered. Now, Mick, as well as other shareholders in this involved in my organization, we have been engaged with a sponsor of the House companion bill, SB158, and we've been working with Representative Stinnett over in the House on this issue. We look forward to working with Senator Brown on this issue with respect to this bill, and we're glad to take any questions.
Questions for the witness? Seeing none, thank you for your testimony. Next up in opposition.
Thank you, Madam Chair, members of the committee. David Willis here on behalf of the Missouri Health Plan Association. We're the association of Medicaid managed care companies that manage the Medicaid population on behalf of the state. There's 3 companies in my association. We manage the lives of about 1 million Missourians on the Medicaid program. Unfortunately, here to testify against this bill today. I want to start by saying we don't dislike gold carding programs. In fact, some of our members have rolled out gold carding programs, both here in Missouri and in other markets nationally. We think they do work and are an effective tool in the marketplace. Our opposition to this bill is we don't like the fact that it is a government mandate dictating how that program is going to be built and enshrining that into statute going forward. We believe that lowers the standards and will increase cost. Managed care companies manage their population and manage cost on behalf of the state in 2 different ways. One is through care management, which is to help make sure that our members have access to the care that they need. We all agree a healthier population is a cheaper population to manage and cheaper population to care for. The second is utilization management, which is the prior authorization process. This would severely hamper one of those 2 tools that we have to manage costs for the state. Hampton mentioned we have been working with the chairman and the sponsor in the House with some changes that we think would make this bill better and something that we could get a lot closer to supporting. 2 of those things I'll mention that aren't contemplated in this bill. There's no quality component, outcome-based component on what happens with that provider. It's just a straight 90% threshold. If you meet the 90% threshold, you continue to get those prior auths approved. The second is, and I think this goes a little bit to your point earlier, Senator Gregory, is there's this only focuses on the number of claims, the number of prior auths. It doesn't factor in what the value of those prior auths are. So you could be very compliant on low-dollar prior authorizations and significantly less compliant on high-cost prior authorizations, still hit the 90% threshold, but the dollars would be wildly askew in that formula. I'll leave it there in the interest of time.
Questions? Seeing none.
Come grab me offline so we can talk more. Thanks.
Sounds good.
Thank you for your
Thank you.
testimony. Next up in opposition to Senate Bill 230.
I'm Chairman Shannon Cooper today, representing America's Health Insurance Plans and Blue Cross Blue Shield of Kansas City. And I hate to burst everybody's bubbles in here, but you could pass this bill today, put these provisions in place, and about 60+% of the insurers operating in this state would not have to follow these rules. Missouri has some of the strictest prior auth timeframes in the nation. I think the department of Commerce and Insurance will probably bring you by a flow chart showing you how things actually work. But the reality is there is a ton of folks that operate in Missouri through ERISA plan, large group employers that don't have to follow these rules. So we can pass this today, and I can guarantee you we're going to be back in here next year with these same complaints because we cannot regulate everybody out there. Senator Gregory, you hit the nail right on the head. We use this prior authorization to make sure that our members get the most effective care and the most effective place of treatment. We're not doing any of this to hinder or deny care for many of our members. That makes no business sense whatsoever. And I can see you're nervous about the bells ringing. I will stop and make myself available for questions.
Questions? Seeing none, thank you for your testimony.
Thank you, Madam Chair.
Anyone else in opposition to Senate Bill 230? Seeing none, anyone here for informational purposes only? Seeing none, this concludes the hearing on Senate Bill. Senator Brown, did you have any final comments?
Just once again, thanks to the committee for the opportunity to present, and thank you to everyone that braved the snow to make it out. I don't think I've ever presented a bill in the committee that was this popular before.
Thank you. This will conclude the hearing on Senate Bill 230, and we're adjourned. Well, we actually made it in an hour. We made it in an hour. We just didn't get started till late.